hematoma, brachial plexus palsy, and retinal and intracranial hemorrhage. Now we'll look at several other events that can present during labor. How do you assist with a prolapsed cord? An umbilical cord prolapses when, after the rupture of membranes, rather than the presenting fetal parts descending, the cord slips down into the pelvic outlet. The fetal presenting part then partially or completely compresses the umbilical cord, reducing or stopping blood flow to the fetus. Occult prolapse is hidden, not visible, and can occur at any time in labor, whether or not the membranes are ruptured. Visible prolapse usually occurs directly after the rupture of membranes, when gravity and fluid propel the cord out in front of the presenting part. Factors that increase the risk for a prolapsed cord are fetal presenting parts being at a minus station, like -2 or -3, a small fetus, or hydramnios. Other factors include multiple fetuses, an abnormally long cord, that is longer than 100 centimeters, and abnormal fetal position, for example, breech or transverse lie. Signs and symptoms of a prolapsed cord include palpation or visualization of the umbilical cord in the cervix or vagina, and the client feeling the presence of the cord in the vagina after her membranes are ruptured. With prolapse of the cord, watch for signs of fetal bradycardia. If the fetus is becoming distressed, the fetal monitor will show some variable or late decelerations, or a loss of variability. Call for help immediately once you identify a prolapsed cord. This is a medical emergency, and the healthcare team must act rapidly. One nurse stays with the client, while another team member notifies the physician or midwife. Place the client in Trendelenburg, or knee-chest position, if prolapse is suspected or detected. You may also place her in side-lying position with hips elevated on pillows as an alternate position for relieving pressure on the cord. If the prolapsed cord is identified during a sterile vaginal exam, the examiner should exert upward pressure with one finger on either side of the cervix to push the presenting part away from the cord. This action might also be helpful in other situations when the fetal heart rate does not revert to its normal range of 110 to 160 beats per minute. Give the client oxygen at 8 to 10 liters per minute as prescribed to boost maternal oxygen saturation and to help increase the oxygen supply to the baby. Prepare the client for cesarean delivery if birth is not imminent. Give the client and her family simple explanation of the situation, because the anxiety from the emergency can interfere with understanding. It is also important to provide emotional support to both the client and her family. Complications from a prolapsed cord can affect the mother if she has a cesarean section, as she could experience hemorrhage and infection. Fetal complications are related to inadequate oxygenation. If the fetus becomes asphyxiated, fetal demise is possible, depending on the length of time and to the degree with the blood flow and the cord has been impaired. What if your client has a multifetal pregnancy? When 2 or more embryos develop in the uterus at the same time, the condition is known as multiple gestation or multifetal pregnancy. When more than one fetus is involved, morbidity and mortality is increased throughout the antepartum, intrapartum, and postpartum periods. Multifetal pregnancy may be suspected when the uterus is disproportionately large for gestational age. The client can become very uncomfortable during multiple pregnancy, with the oversized uterus causing shortness of breath, dyspnea, backaches, and pedal edema. A major goal is to prevent preterm labor. Therefore, prenatal care should begin early, and more frequent visits are encouraged. Advise your client early in the pregnancy to make applicable lifestyle changes, such as reducing her personal stress level, reducing the length of working hours, and avoid standing for too long. Your client is at risk for multifetal pregnancy if she has a previous history or there is a family history of multiple gestation. She is also at risk if she has taken ovulation-inducing drugs such as clomiphene citrate or Clomid, or has undergone other treatments for enhancing fertility. The first sign of multiple fetuses is a uterine fundus higher than expected for gestational age. Fetal heart rate sounds are often heard in more than one place on the abdomen. Your client might also have severe nausea and vomiting, and her weight gain will be more than the norm for the particular gestational age. Ultrasound is usually done to confirm multiple gestation. Human chorionic gonadotropin levels are usually higher than with a single fetus pregnancy, but they are not usually high enough to confirm the diagnosis of multifetal pregnancy. How will you care for a client with multiple fetuses? A weight gain of 40 to 50 pounds, that is 18 to 23 kilograms, is expected with a twin pregnancy. Therefore, you would recommend a daily intake of about 4,000 kilocalories for your client. Because of the potential for preterm labor, advise her to avoid standing for prolonged periods of time. When your client is in labor, prepare her for cesarean delivery if appropriate, but keep in mind that some women with multiple fetuses do deliver vaginally. Plan to have enough nursing staff available to assist with the additional newborns. Prior to delivery, prepare the delivery area with resuscitation equipment for each infant. At delivery, a separate neonatal team is usually prepared to care for each baby. You will also be responsible for correctly identifying each newborn. What if you see meconium-stained amniotic fluid? As we've already identified, meconium passed prior to delivery turns the amniotic fluid green. There might also be heavy particulate matter in the fluid. If the fetus becomes distressed and hypoxic, the anal sphincter relaxes and the fetus expels meconium into the amniotic fluid, thereby staining it green. Presence of meconium before the onset of labor does not always indicate a problem. The fetus might even pass meconium without being stressed, or the stress may have been temporary. When meconium staining is detected during labor, however, you'll do an electronic fetal monitoring and perhaps fetal scalp blood sampling to determine fetal well-being. To prevent and detect meconium aspiration in the neonate, monitor the fetus very carefully. The newborn's trachea will be visualized and suctioned to prevent meconium aspiration syndrome. You're likely to see meconium staining with postterm and small for gestational age infants, as well as with breech presentation. If there is fetal distress or a prolapsed cord, expect to see meconium staining. Or if your client has an intrauterine infection, such as chorioamnionitis or Listeria vaginitis, the chances of meconium staining increase.